All right, I'm the oddball out here because I'm going to talk about the baby now, not just the mom. All right, so in management of these women and these babies, first and foremost, I've had the opportunity here in Syracuse to start a prenatal consult program and have my social workers at Crouse Hospital specifically say to me, what a difference in what some of these women come in. It used to be that it was all anger because you didn't talk to them until they were delivering. Wrong time to talk to a woman about these issues. She's just had a baby, now you're telling her she's positive. And moving it back. So the prenatal consult with someone, whether it's a pediatrician, neonatologist, anyone who can get to her before she's in active labor and discuss your institutional policies, whatever they are. I hand her the consult. I hand her the pamphlet exactly outlining what to expect in black and white. You and your baby will be, and I will circle it in red, in the hospital a minimum of X days. You and your baby will, and we go through it line by line. I give her our scoring tool. I want her empowered with information before she delivers so she can participate in care. My first words as she walks into the office, congratulations on your pregnancy and your soon-to-be newborn. I do not judge you. Your past is your past. I'm here to give you information and hopefully dispel myths. The shoulders that go from here to here with those two sentences are extremely powerful. Once we've had the prenatal consult and she is in the newborn nursery or the baby's born and maybe we didn't know, it's identification of the risk newborn. Every hospital has policies. Who do we screen? Who do we not screen? I am a fan, I'll say it now, of universal newborn drug screening, period. We universally drug or HIV screen every newborn in this state and in this country. I don't know if you realize that, but on the New York State newborn screen, HIV testing is occurring. I do not ask permission. I don't necessarily discuss it all the time, but I'm doing it. I am a true fan of it because then it allows me to help take care of that baby and that mother. The NAS scoring tools, there's many, many out there. We use a modified Finnegan here at Crouse. Every institution is different, but it's something that you need to explain to these women, and they need to participate in the scoring. If it is done only by us as healthcare providers, we might as well have just shut the door in their face. Allowing them to participate with that scoring tool allows them to see really what's going on. And they are there watching their baby. We don't have a camera on the baby. So when we talk about treatment of neonatal abstinence, I think of neonatal abstinence not just as opioids. We have a lot of other agents that can cause this same picture. And so we have to be careful in how we identify and what we're looking at. Importantly, you need both non-pharmacologic, swaddling, breastfeeding if at all possible. For the mom who's in a program, she needs to be encouraged to breastfeed if she wants to do it. And we need our lactation consultants there holding her hand. Not that she's an addict, she's a mom first. She's there, she wants to do this. If there's no absolute contraindication to breastfeeding, we must support this for her because it's going to improve bonding and there's a really good chance that baby will not go to the NICU. Quiet environment. I ask every one of them, tell me about what you wanted when you were in withdrawal yourself. And I said, make that happen for your baby when they're born. I said, you can blame me and tell all your family they're not allowed to come to the hospital and see you and the baby. You can blame me when I say cell phones have to be on vibrate, turn the TV down, put the shades. I said, because you want to give your baby the environment what you wanted when you were in withdrawal. Let's prevent this baby needing the NICU. If we do need pharmacologic treatment, there are many agents, there are many different programs. A lot of research on buprenorphine now in the neonate. A lot of that is still at a research level and not standard of care. I expect the information will be coming out in the next few years, whether that will be a first-line agent in nurseries. All right, so barriers and challenges as a pediatrician. There are a lot of no prenatal care still, and I think that gets back to the question of the screening versus testing, though we also universally now pretty much screen for syphilis, don't we, in the OB world? You know, we now are offering all these things. We do GC, we do chlamydia. Do we actually ask permission to do all of this? I mean, just we're doing all the standard of care, and maybe we as providers need to relook at how we present what's important for the overall pregnancy period. Not that it's a stigma, not that it's a judgment, but it's how do we help take care and maybe refocus our verbiage. The stigma of the bad mother, not only in treatment, but I do get that question all the time. How do I get looked at? Am I going to get the pain medicine? If they see that I'm an opioid user, that means I can't have it. I'm like, you are a mother first and foremost. Yes, you have a chronic disease with addiction, but you are a mother when you come in. And we need to really emphasize that. In the NICU, they do feel like they're bad mothers. They feel that other mothers are looking at them. They feel that other nurses are looking at them, the providers. They will go to the provider that will talk to them and say, I'm not judging you, I'm here to help take care of you. Prolonged hospitalization. Unfortunately, if the baby needs treatment, baby's going to be in the hospital 7 to 60 days on average, 21 to 28, depending on single substance or polysubstance. That prolonged hospitalization equals poor bonding, separation from the family, and all of those problems. Here in Onondaga County, Kathleen, I saw her somewhere in here, myself, one of the local pediatricians, we've been talking with a local agency about how do we stabilize in the hospital, get the baby comfortable, and then can we get mom and baby someplace, outpatient program per se, but that they stay and learn to bond and we finish weaning so that we're not in the stigma of the hospital anymore. It's around the country, it's starting. It's a difficult concept and funding is really hard. I'm going to go back to Dr. Gary's point. These babies do great on methadone and buprenorphine. The drugs don't influence the development. The environment in which the child is raised is how the child will develop. Put them in a box, they become a box. Put them in a family who wants to love them and do everything for them, that child is going to thrive. And we know that because of children who've gone into foster and adoptive families who have really worked and helped that child, and those children are beautifully normal. You put them in an environment where it's disastrous, you're in trouble. All right, resources. Remember the pediatrician, remember the neonatologist, and then once they get home, please remember the community has lots of resources between child find, early intervention, and treatment programs, whether inpatient, outpatient, but we need to work as a group. Questions?